Eloise Osbourne, who graduated with a Master of Public Health from Macquarie University. She's recently completed an internship in public health research with a focus on Indigenous health here at the Poche Centre, and also with the Wollongong Maru at Macquarie University. She's presenting today on access to healthcare in a remote New South Wales Aboriginal community. Over to you, Eloise.
Thank you. I'll just share my screen.
Yep.
Great. Everyone's able to see that?
All good.
Okay. Hi, everyone, and thank you so much for having me here today. I would like to echo those before me in recognising the traditional custodians of the lands that we're on today. I'm on Cammeraygal land, and I would like to pay respect to Aboriginal elders and leaders past, present and emerging. Today, I'll be presenting our mixed methods study, mapping access to healthcare in one remote community that's been worked on by this author team that you can see on the slide here. This research paper stemmed from the mapping study that the Poche Centre worked on in 2016. In this study, investigators worked with 3 regional New South Wales towns with proportionately high Aboriginal populations to map the accessibility of healthcare services. The study was co-designed by investigators and communities, as well as the local ACCHOs and other health services. Participants, who included health workers, Aboriginal health workers, education workers, community leaders, were asked to structured quantitative questions about the accessibility and frequency of health services in the community, as well as longer qualitative questions about factors affecting service availability and utilisation. The protocol paper for this study and the qualitative data from this study have both been published in 2019 and 2018. The paper I'm presenting today focuses on one town and uses a mixed methods approach. We used descriptive statistics to analyse quantitative data to demonstrate the availability of close to 40 health services in the community. We also did a thematic analysis of the qualitative data with quotes and observations from interviews to demonstrate the implications of the findings. This came out of interviews with 11 participants who were Aboriginal and non-Aboriginal professionals in the community, including 4 participants from 3 local health services, including an ACCHO, 5 participants who were staff at the 2 local schools, and 2 participants from fly-in, fly-out services. This approach meant we were able to do a whole system analysis of healthcare in the community, where we were really able to get into how the health system worked, what services were available, and to gain an understanding of the gaps of access to services across the community. We discuss in this article through 3 important themes. First, the discussion of service availability and examples of over and under servicing. Second, the system reliance on nurses, community health workers, Aboriginal health workers, teachers and administration staff. And lastly, the implications of travelling and telehealth services for healthcare access. To understand health service availability, we looked at services by whether they were local or provided as travelling or telehealth services, as well as how frequently each service was available. We saw that in primary health, there was good local availability, particularly for nurses and community health workers who were always available in the community. However, people were still having to travel to see a dentist or doctor when appointments weren't available. And we don't see any utilisation yet of telehealth in primary health in this community. For specialist health, there wasn't any local availability, but often specialist services were available at a reasonable rate, which was perceived by the participants to meet most needs of the community. However, there were still serious gaps. And we start to see the utilisation of telehealth, particularly in follow-ups. In terms of allied health, some services were available locally, particularly speech therapy, and there was the regular availability of key allied health services, including dietitians and counsellors who came weekly and fortnightly. One of the key themes that emerged from this data was the instances of over and under servicing in the community. There are quite a few examples of doubling up of services. For example, counsellors and dietitians, of which there were 2 of each, would come to the community, which often created a sense of confusion if the same treatment plans weren't followed by different specialists that were seen. Additionally, there were 2 podiatrists in the community that came to the community, one who was receiving funding to see only Aboriginal patients who had chronic health conditions. So a second podiatrist was needed to see the other patients in the community, including Aboriginal patients who didn't have a chronic health condition and non-Aboriginal patients. And we saw from our interviews with service managers that this over-servicing was often due to systemic problems with funding, which made it harder for them to facilitate interagency communication and cooperation. This also had a negative impact on their ability to provide a diverse range of services targeted to meet the community's needs. Another key theme was the significant reliance that this system had on nurses, community health workers, Aboriginal health workers, teachers, and administration staff. These workers were incredibly resilient in providing care and really went above and beyond to meet the gaps in the health system and to meet the needs of the community. We see that Aboriginal health and education workers were really important to building trust between health and education services and Aboriginal families, that nurses were highly trained and had first-line emergency care training as well as dialysis training, which really helped meet some of the needs of the community. And teachers had a really important role in facilitating healthcare access, both through the school's role as a health hub, but also through supporting families through their child's treatment. And we can see from the quote below that this was just really important in terms of parents being able to meet their child's health needs, because the teacher would be able to facilitate discussions with doctors, be able to help explain the condition to the parents and the treatment, and to also support the treatment programs through school. A final theme that was really important to understanding the availability of health services in the community was the use of travelling health services and telehealth services to provide care. These services are a really important part of rural and remote healthcare and reduce the need for patients to travel to health services, which we know reduces the likelihood that these patients will receive treatment. However, local health providers had very mixed opinions about the appropriateness of these services to meet the needs of the community, particularly with the over and under servicing in the community. So while some people felt that there was similar access in cities where wait lists influence availability as to in rural and remote places where the frequency of visits impact availability, there were really clear instances of over and under servicing where this wasn't quite working. For example, people in the town often joked that the optometrist came so often that everyone in town had a pair of glasses. And conversely, there were very advanced cases of poor health and a sentiment that travelling health services couldn't do enough when there wasn't enough ongoing care available locally. And this was particularly true for diabetes care. Because this study was done in 2016, telehealth was only just emerging. It was mostly being used for specialist healthcare and emergency healthcare. And there was a general sentiment that while telehealth could be really useful, there wasn't enough consultation or training, so staff weren't always comfortable using it. While this was a really small study, it really demonstrates the interaction of many complex interconnected factors that influence rural and remote healthcare, as well as Aboriginal healthcare. So thank you all for listening.